So I'm Ben Wood with the Department of Public Health, and
Kathy O'Connor.
Kathy O'Connor with the Department of Public Health, and we're going to have what we're calling a listening session. We have some information that we want to provide. We're going to talk about some lessons that we've learned about the Determination of Need Community Health Initiative program, and talk about some ideas that the department has for moving the program forward, and just have time and space for conversation around the recommendations. But we have a series of slides. We actually haven't practiced this, so we're not exactly sure how long these slides are going to take, but I think it's probably important to get through them, to provide context and background. And I think also realizing that there's probably some people in the room who live and breathe this stuff, and maybe some other people who are interested in it but aren't living and breathing it. So I think we can find space to to meet all those needs and perspectives. So Kathy, I think actually you're first.
So I'm
we'll be informal, so we can have conversation during the slides. But if that seems like it's getting too much into the weeds, I think maybe we'll table discussion until the end. But if you have a burning question, don't hesitate to ask it.
So as Ben said, we just wanted to lay a little bit of background because we figured there's probably some people in here that haven't really been as involved in the DOM process over time, or the part that we are going to be basically talking about, which is a study that we conducted to look at, how is it going? How, what's happening with the DOM? And so the reason that we were thinking of doing it at this time is that, we know, and people have been talking about this all day, with the advent of health reform, it's really changing the environment, and it's really a time for people in public health to be able to figure out how to step up and really be a partner in that. And so what does that mean for us? And also to think about the role and structure of community coalitions. But as we know, in Massachusetts, it's a very complex environment when it comes to coalitions. And, we have ongoing and long-term coalitions like Chenaz that, have been around for a very long time. There's some substance abuse coalitions that have been around for a very long time. And then there's a lot of things that have been built up over time or are emerging to address issues. And so we have to think about that and figure out how we're going to interact with that. So for those of you who don't know, what is a DON? And so basically a DON is determination of need, and it's the department's obligation to figure out how to make sure that certain healthcare services are available and accessible. And so it's actually legislatively required that there be this process. And most of the applicants of DONs are healthcare facilities, many of them hospitals, but sometimes there are other MRI or other companies that also have to use DONs. And basically, therefore, new technology, substantial capital expenditure, or change in service. So there's a lot of things that happen that don't require a DON, and there is a threshold of money. So sometimes people will call me and I see them building something over there. How come we don't have a DON? It didn't make the threshold. And the Public Health Council is actually who approves after it's analyzed by the staff, which is DPH. They do the approval. So as part of that, in probably around 1992, there was an establishment of a community health initiative that was all applicants were obliged to comply with. And usually it's 5% of their maximum capital expenditure. So that's how much the project costs in general. And so those of you, there's people in here I see that have projects, so you know what I'm talking about. And it could range from, sometimes projects might be, I don't know, $100,000 all the way up to $200 million, $300 million. And they are either paid when the project is implemented, which means when they open their doors, and sometimes on approval. And we have never waived a community health initiative to date in the department.
Oh, okay, so
You're next.
that's up to me. All right, so it was, I guess, just about a year ago that we were really in the middle of a assessment project looking at the DON-CHI program. And we followed the 6 standard steps of a health impact assessment. So, you know, that is not terribly important, and I think actually a caveat being that one of the things I do at DPH is support the practice of health impact assessment, and this actually was a very untypical health impact assessment. And if there are people who are really interested in that topic, I can explore that with them more after the session. We can talk about it and find other space to do that. But what it did do is it provided us with a very nice structure to conduct an assessment and a sort of a look at the operations of the DON-CHI program. And one thing about HIA is that it is structured around a decision-making point. So you're trying to inform a pending decision. And in this case, it was a very broad-based decision, and it was the charge of the commissioner essentially just to ask, if we're not going to make any changes to the current operations of the DON-CHI program, what is going to be its long-term population health impact? So these are the 6 steps of a health impact assessment: screening, scoping, assessment, recommendations, reporting and monitoring, and we're currently in this very elongated reporting stage. We actually finished the project, I'd say probably around the end of August last year, and we've just been internally at DPH thinking about it and having conversations, and of course with leadership changes and things that are just typically slow. So this is just a very high-level view of the assessment project, so you just have a sense of the process that we went through and the sorts of things that we did. So we started with the scoping phase of the HIA. Scoping is where you're trying to get as many different perspectives about how the current sort of status quo of a program is going, or how it is that people think that the pending decision might be impacting them. So the way we started that was to have a series of guided interviews, and we did that with folks from DPH, a lot of hospital stakeholders and community stakeholders. And when I say community stakeholders, I mean primarily stakeholders who are coming from Chenaz. And we made that decision because Chenaz has historically been the community-defined partner in the DON-CHI program. And then we also had conversations with academic folks who had experience looking at how hospital systems are making community health-based investments, which the DON-CHI program does. So from that, there were 6 emergent themes, and just to go over them real quickly, one is just people's understanding and conversation around what is the overall driving purpose of the Community Health Initiative program. Lots of issues that people were brought up around ongoing decision-making dynamics. Who has power in this sort of general trio of conversations between DPH hospitals and community stakeholders in terms of how investments are being made. A lot of conversation around the geographic context of investments, so literally where these DON projects are happening, and therefore where resources are available to expend for community health initiatives. Issues around setting priorities for funding allocations. You can imagine what that all means. Lots of just open conversation around what it actually means to have a successful community health initiative investment. How is it that different stakeholders are defining success? And then lots of conversations around alignment and integration with other types of initiatives and priorities that are generally in the same sphere and realm as the types of things that the Community Health Initiative program is making investments in. So after that process of going through and developing those themes, we conducted what we're calling the assessment, and it had 3 major legs to it. One was a request that we made to Chenaz and to hospitals to look at existing documentation that they had about the types of investments that they've been making over a period of time. We did as much of a quantitative analysis as we could using a database that DPH maintains that keeps track of DON-CHI investments, and we looked over a decade period. And then we did an online survey of 2 hospital and Chenaz stakeholders that have been very much a participant in implementing DON-CHI programs from fiscal year 2009 forward. So we wanted to look at the more recent past, because there was a a change in guidance around 2009, and looking back prior to that didn't seem to make too much sense. These are the areas that we identified as being ripe for ongoing conversation and discussion about. You should always turn off your cell phone when you're giving a presentation. These are the areas that we found were really ripe for thinking about a recommendation. So very much along the lines of the same sort of issues that were raised during scoping. So trying to figure out ways to remedy the fact that there is inequities in the geographic distribution of these DON-CHI funds. Trying to think about issues related to decision-making and these sort of power dynamics. Lots of issues related to evaluation and measurement and the overall impact of these types of investments on health outcomes, whether or not everybody loves it or not. We live in an environment where measuring impact is more and more important. So coming to some general consensus around what it is that we're trying to measure is really important, both at the broad level in terms of the overall DON program, but also at the individual investment level. And then lots of issues related to the integration of the DON-CHI program with the community benefits processes that hospitals have to go through, and sort of thinking about how we can influence hospital-based practices using the DON process. So this is, I think, really important. We, as it's just sort of an overall, that was very glossed over, that was very high level, we're not really showing you any real data. I think one of the things we just wanted to communicate to people is that the project itself affirmed that this is an absolutely just critical program that we need to see is maintained and enhanced, that there is very little other sort of stable resources out there that can make investments in the social determinants of health, that can really drive a primary prevention focus, especially coming from hospital resources. So it is a critically important program for us to figure out how to enhance and continue. And I think that we identified areas that we think are going to change the program a little bit, hopefully improve it. We'll see about that. But not necessarily fundamentally in any way, totally restructuring how it currently operates.
So when we came up with these sort of the recommendations, or what we were trying to say, like what is this sort of the overall thing that we're trying to do, is we really wanted to see if we could use the DON program to continue, because I feel like it actually has been working on transformation, but really a commitment to transformation, particularly, as we said in the beginning, as hospitals are shifting to a population health focus. And there was our keynote speaker today, I think, was very eloquent in describing some of the issues around that. And so how do we work to make sure that hospitals are authentically engaged with the community? And how do we create collective impact? So this is what we were trying to achieve with the direction that we're going forward with. So so one of the things I think isn't really exactly news, but really to reiterate and to focus on, is that we really want to invest on those public health priorities that address the social determinants of health. So we have been, I think, over the last several years, even under the old guidance, starting in that direction, but to really keep that going, and to encourage hospital investments that really have a primary primary prevention focus. So, the other, I guess, I don't know if this is going to show up here.
What's that?
About the community benefits part, is that in here? Because otherwise I was just going to say it now. Oh yeah, okay, no. So that's the next part of it. Is also to focus on investing in ways to encourage hospitals also to think about the way they do their community benefits to kind of align with this social determinant approach. And so how can we use, I was thinking we were just in the community assessment piece of this, and some of the things that people were talking about actually were from the direction of the department to encourage the use of this DON money to do community health improvement plans. So there is a role for the state to set out sort of a vision and to set out guidance that really can help to encourage change. And then we also want to look at and think about how do we use this money to address the issues of inequitable distribution of funding based on the location of hospitals. So this is something that we heard like kind of loud and clear, that areas, particularly rural areas, but I guess not only just rural areas, that have either community hospitals or have small numbers of hospitals, really don't have any DONs.
They don't have the money to do those kind
Right,
of.
so they don't have the money to do the investments, or,
Infrastructure.
yeah, or the investments they make are much more modest.
Yeah, they're
So they
trying-
don't hit
they're doing
the
some.
ceiling. So it's not like they don't do any investments, but they usually, you know, don't make it to be actually a DON investment. And so how do we think about that, and how do we also address the issues of sometimes population-specific work? So that was the other thing that came up, that, you know, might be ways that when we were talking this morning about equity. And so how do we continue to focus and look at, you know, particular populations, perhaps an immigrant population that might not be exactly aligned with the hospital catchment area. Oh, I have one more. Oh yeah, and so yeah, and the other thing that we really wanted to make sure is that the DON program be measurable and accountable. So, you know, this is, I guess, the kinds of things that we've been hearing, and it's just something that I don't think is going away, that we do have to figure out how we're going to demonstrate that these things are working, make sure that, like, everyone knows what we're doing. We were talking, that's another kind of CHIP thing as well. When you're doing a community health improvement plan, if you have a big community, and even if 100 people are working on it, how do 500, how do 2,000, how do, you know, 100,000 people know what you're doing? So how are you accountable to your whole community?
So based upon those basic vision statements, and just reiterate what Kathy said, it's not that a lot of those same sort of priorities and principles weren't always part of the DON-CHI program. It was just an opportunity for us to reframe and try to focus in on areas that we wanted to emphasize. Based upon those vision areas, we have a series of recommendations that we're going to get into in a little bit more detail, but really briefly, it's about how the DON-CHI program can be used to facilitate in a more intentional way the integration and alignment with hospitals' community benefits requirements, and very much around thinking about the process that all sorts of organizations, but definitely hospitals, are undergoing to conduct community health assessments and community health improvement plans. Recommendations around the quality and focus of the coalition that the DON-CHI decisions are being made in partnership with. Recommendations related to how DON-CHI investments align with or don't with other statewide initiatives and priorities, and recommendations related to the measurement and evaluation of community health initiative investments. All right, so a little bit more detail on these. So this first recommendation, and it really was good to be coming right from the workshop that we came from, which was all about sort of emerging best practices in community health assessments and development of community health improvement plans. This recommendation is essentially trying to get us to one step closer to this maybe make-believe land that we all hear about of hospitals really transforming their business into a population health focus, and really sort of figuring out ways for community organizations, the public health community, who's also really learning about how to help with this transformation. So how is it that we can use the DON-CHI program to really intentionally spur this process along and make it a little better? And through conversations with stakeholders, it was obvious that sort of thinking about the process of community health assessments And the process of developing community health improvement plans was a way for us to really dig in there and figure out some good best practices. So this recommendation is really all about, and we heard this in the last session too, and I think that probably everybody has felt this to a certain degree, that we want to try to push a perspective that we're trying to minimize the oversaturation of community health assessments in communities. And try to reduce redundancy, try to make community health assessments better, and really with the eye on the prize of a more robust community health improvement plan, that there's really broad-based buy-in from a variety of different organizations, so that we can sort of further along this path of the buzzword of collective impact. And really trying to think about how it is that the DON program can be, because it's a program that DPH has leverage over. We don't have the same leverage over the community benefits process. How is it that we can use the DON program to have the perspective of a more community-based health assessment and health improvement plan that is driven by a hospital be more community driven? So more specifically, yeah.
There's a question.
So I have a question about that. Because typically the DON funds have been used to support whatever comes out of the community assessment. Does that not then take money away from that process? I mean, if you're going to start putting that DON money towards the assessment itself, then how do you support the initiatives that the assessment says are needed in your community?
Yeah.
Typically, that's what we've used those funds for. So to have them taken away to be used to do the assessment itself wouldn't necessarily serve all of the population.
So that's not like, it sort of says that, but it's not, it's just partly that. So here where it says, well, not supplanting other dedicated resources, because that's something was really sensitive towards, that, hospitals just don't abdicate their responsibility to do community health assessments. But sometimes it's appropriate for the assessment maybe to be expanded, for example, and so a contribution could be made also. And then also it sort of in a way gets you sometimes a more credible place at the table to engage with the rest of the community. But it definitely isn't meant to supplant it.
Absolutely not. Yeah, we want to see hospitals expend their community benefits resources, and we want to see the DON funds be leveraged to see that those resources are being used in a way that is really sort of furthering a more primary prevention focus, is really kind of the gist of it. So we're going to be thinking about how during the application process that the DON applicant is demonstrating that their proposed process for making investments is coming from a community health assessment and a community health improvement plan, and then really with strong attention being paid to the quality of that community health assessment and that community health improvement plan.
Ben, you may be getting to this later, so tell me if you are. So currently, when a hospital files their DON with the Community Health Initiative, they have to say how they're going to use the money. And then there's a process to decide how they're going to use the money. So can you clarify that in terms of the CHI requirements in the DON, how specific they need to be, if there's going to be some kind of a partner community process after that?
Yeah, well, we should also caveat that a lot of the details to be determined. However, one of the things that we've been thinking about is how can we make the upfront application process a little bit more detailed than it has been. And one reason for doing that is because there's more of a stick in the approval process for the overall DON. Right, so if we can identify some deeper issues on the front end of the DON application, we can maybe try to interject and try to address some of these issues more on that front end. Is that what you're saying?
Well, and David, just to add to that, I know what you're saying. And the other thing is that, we're trying to also switch the timing of this. So when hospitals file a DON, usually there is a 4-month requirement for the department to look at all the details, and generally they're required to then make a recommendation to the council within 4 months. So those 4 months are the chance now, like sometimes it was always so short that there wasn't that time, so we're trying to push it up so that there's more conversation and planning ahead of the public health council meeting, because we do feel that that does give a little bit more leverage to the process.
And
But-
would include community partners.
Right, yes, exactly, right. So maybe the initial, and we'll kind of get I mean, that's also some of the stuff we want to hear about too, but, no, go ahead.
Thanks. Yes.
With community health assessments and CHIPs being done more collaboratively across the community, hospitals are having to adopt by their board of trustees, in particular their versions of their community health needs assessment and their implementation plans. Is that what you're referring to, the hospital approved and adopted CHAs, or the community whose CHA? This is the question.
What we want to see, I think that the goal is that there is a community-driven community health improvement plan that the investments of a CHI program is investing in is derived from. So as the applicant, the hospital is going to need to demonstrate that it is part of a process that has a more community-based community health improvement plan underpinning it. So whether or not it's the hospital's approved community health assessment that they use for the IRS, I'm not necessarily sure that's going to be our business per se. What we want to see is that the hospital is using better community-based processes in the development of its JHA and CHIP, and that the CHI is going to be investing in those areas, hopefully spurring the adoption of a hospital, more embracing those types of plans.
For clarification's sake. So we may be doing hospitals are driving community health needs assessment process because they have to, they're regulated now on a 3-year cycle. That assessment may or may not be adopted by groups outside of the hospital. So what version of that assessment would be used to determine this? I'm so sorry.
No, I mean, like as Ben said, this is Shangri-La.
Okay.
And we're hoping that over time, that because, the IRS set this in place without really, I think, understanding how important it is for community to be involved. So hospitals are on the line because they're the ones that are obligated to the IRS. However, that sort of changes the dynamic, right? Because, if you're saying, well, the hospital's the driver of it, whereas what we would hope is that, it would be a collaboratively driven process that could be both adopted by the hospital and agreeable to the community, or at least some intersection of that. So that's what we're trying to use this as an opportunity to influence.
And I think everybody's of that same opinion, that that's where we're trying to get to.
Yes.
However, beyond just the assessment, hospitals are on the line for the implementation of those plans, and monies associated to that implementation as well. So there's a plan, a hospital's coming to the table with the assessment, however it was done, hopefully very collaboratively across the community, but also being regulated to invest on an implementation plan for the very things that were identified. So the implementation plan is already part of what the hospitals adopt.
Well, that's the whole, I think, point of probably
Yes.
the community health assessment. And the idea is, though, that when you think about it, a hospital has a really, in a way, a small amount of money to invest, right? You're not going to change the community with the amount of money you're investing. If you have a community health improvement plan that also then now gets other partners in it, you might be implementing different pieces of it, but the idea is to be kind of driving down the same road in terms of how you're thinking about utilizing this money. So it's a process. I don't think it's going to happen like in a day.
You were in the last session, so sort of thinking about Worcester as a best practice example, and having the hospital be a participant in a broad community-based community health improvement planning process, that it has its sort of its pieces that it's attached to. The health department has its pieces that it's attached to. Community-based organization X has its pieces that it's attached to. So we want to sort of start to try and use whatever leverage that we have as a department to further those types of collaborative planning processes, so that there's shared indicators in the community, there's shared measurement opportunities, and there's the possibility of leveraging resources together.
I also think the strategic implementation plan is only going to go so far, because it's really more contained by the hospital and partners, but then opening it up even greater to do a community health improvement plan, I think is when you really start to see some of these, some shift happen. So, unfortunately, the timing is not always the same of these plans, so I think that's the challenge is, one maybe in year 3 and the next one's in year 1.
Right.
Really try to align those.
Yeah, and I could just share, that's a great point. I could just share one idea that was in this past session too by Frank Robinson at Bay State, and he was there in this cycle. There's all these cycling issues. And he said, oh, maybe we're going to start moving toward this. This is his idea. He has got to get broad buy-in for it. But maybe we'll be doing an assessment every year. And we're just going to be doing different pieces of a sort of a broader vision of what a community health assessment is. Little slices every year, deeper dives into this issue, little surface dives into these other issues, but really sort of thinking it on a more routine basis in this every 3-year cycle. The other thing here, just to pay attention to, again, this is also using Worcester as an example. There aren't going to be a lot of these examples because accreditation for local health departments is a very high bar that probably is too high of a bar for a lot of health departments in Massachusetts. But one of the things we're going to want to be seeing if a local health department is moving towards accreditation, that we see the DON CHI investments really sort of intentionally supporting and aligning with those processes as well. All right. Recommendation number 2, and this relates to the quality of the coalition that the DON CHI partnerships are being made with. Through the assessment project, we heard there's a tremendous variability in the form and function and capacity of the coalitions that have traditionally been working through the DON CHI program. We heard different recommendations and different ideas for sort of thinking about how to address that issue. One of the things that has transpired since our assessment project is that the department has been undergoing a sort of more system-wide look at the way that the department wants to be interacting with community coalitions, and how it is that the department can provide some more flexibility to the definition of a coalition, but also some structure to coalitions. And Mike Coughlin has been leading that for the department, and if there are specific questions about that, Mike could probably chime in. But one of the things that we decided to do with the recommendations for this is to basically align with how it is that the rest of the department is moving forward with thinking about working with how it is that the department is framing how its applicants to its programs should be working with coalitions. So there are a series of criteria that have been developed basically to sort of understand what are the basic levels of functioning that we would want to be seeing in a coalition, and assuring that any applicant to a DPH program is going to be meeting that bar. So the other thing that we heard in relation to this recommendation was through stakeholders that we talked to during the assessment project, and a couple of different ideas for how it is that DPH could evaluate the types of coalitions that would be coming into play through the DON CHI program. And the recommendation that we fell on was to sort of think about a way to tier or rank coalitions. The basic idea here is that DPH, as the entity with the regulatory control of the DON program, can be hands-off, it can be very hands-on, and I think the idea here is that we will be less hands-on. There will be less of a sort of overall sort of management role for DPH if the applicant is coming in and working with a very high-functioning community coalition that they're making decisions with. And using the new criteria that are being developed by DPH as a way to sort of create some sort of a ranking system is our basic idea for this recommendation.
So Kathy knows I have a question about this. Coming from a Chenal that's typically done the, distributed the DON and done it very successfully, I think, for all the years that we've had it. I'm concerned that some of the coalitions that get looked at are very issue specific. So, and this is what I was hearing prior to today. So if there is a substance abuse coalition that's working a little bit better than the Chinar in that area, or maybe there isn't a Chinar in that area, because some of them have died out, then that substance abuse coalition might be the entity that then partners to distribute those DON funds. And my concern is that those are one-issue coalitions, and they don't look at a broader sort of, more public health view of the whole community, such as Chenaz have tended to do historically. And we argued for this before, that we would rather see Chenaz made more robust with some help, as opposed to giving the monies out to coalitions that are one or two issue coalitions. Not to say that, even on the Cape, we have a wonderful suicide prevention coalition, housing coalition, substance abuse coalition. But the Chenal looks at a broader perspective than those do. And so I'm wondering how that's going to play out.
That we put it in there for is the longer term aspirational goal that there will be more robust and more statewide, system-wide community health improvement plans in existence. And with that, there might be a very logical reason for a specific case to be making a specific investment with a specific issue-specific, a lot of specifics, with an issue-specific coalition. I think that's probably more of an aspirational goal rather than a status quo objective for the time being. I think that we all want to see that there continues to be broad-based coalitions that hospitals are working with. We want them to be high-functioning, and I don't think there's any intent behind these recommendations that this precludes Chenaz. I think that probably the fact is that where the Chenaz is high-functioning, that's going to be the logical partner for everybody to continue to be working in partnership with each other. The overall goal that the department is moving towards with this new framing of criteria for coalitions is simply to provide a little bit more flexibility. So instead of saying you're required to do this, there's more flexibility now, but these are the standards from which we expect people to be working from.
And I think that also, we have to figure out how, I'm thinking about this morning again, how we work in communities across all the various interests, right? So, there are people that are going to come together around a particular issue, but it's of common concern to the whole community. So, we have to figure out a way that both whoever has the expertise at the moment could implement something with a broader input from the community. And so, this is really about social determinants too. And so you really usually don't address social determinants by an issue-based coalition anyway. So, I think that it's just trying to allow for the concept of that to happen, and/or for a coalition to possibly be sort of the lead in implementing a piece of a broader plan.
How about over there?
I'm wondering if
Can you say your name?
Tina, if you could speak a little bit about your idea about the inherent tension between a regionalization and an accredited health department that has to meet specific goals and a more broad-based grassroots China that doesn't have to be credited, doesn't have to be, meet certain guidelines?
That's in the context of what? Do you want to be a little bit more specific in terms of who DPH would you mean who we would prioritize wanting to see the hospital working with?
Maybe? Is that how you would be thinking about it?
I'm just trying to understand what the question might be.
So you have you said in the slide before about the accredited health departments that may or may not be working with the CHNA, with the hospitals. And then you have the CHNAs, which are more loosely affiliated groups that don't have to be accredited. And is there some inherent tension between a group that has to be accredited and meet certain expectations as opposed to a group that may be more able to think outside the box or meet, affiliate on along different lines than a health department would be? Or have different authority, would the authority rest with the accredited institution as opposed to the, I use the word CHNA since that's what we've done before. I'm just wondering.
I think there's lots of ways to answer that. I think that the reality actually is that very few health departments in Massachusetts will be going for accreditation to the Public Health Accreditation Board. Mike might have a different opinion on that than I do.
In the short term, you're right.
Yeah. So in the short term, that's probably the reality. I think that the overall thing that we're trying to say here, though, is that there are multiple processes going on, a lot of with overlapping types of requirements and goals, and we want to see the DON program be leveraged as much as possible to reduce redundancy and to spur the relationships between the multiple organizations that are working together so that we can be striving towards collective objectives and collective indicators that we're all working from.
David?
I just want to add a comment about, you said that DPH will be having a less hands-on process in places where there are functioning community coalitions. The concern I have is, if that's what I understood, and the concern I have is that I think the role that DPH has played in in the planning discussions is, in a way, a kind of neutral party that equalizes the power between the large institutions and community groups. And if DPH isn't hands-on, then whose process is it?
Let me clarify to say that the less hands-on would be the same hands-on as the status quo. The more hands-on will be a different level of involvement and oversight.
Okay, that's helpful, thank you.
What are we done? 3:45?
4 o'clock. No, 4, so we want to make sure we have time. So go ahead.
I wanted to mention that I really, and I've talked a little bit back and forth with Kathy about this, that I should say I work for DPH. I'm the Director for Rural Health in the department, so I should make that clear. And I think that you're doing some good thinking with this DON money, but to me that's only one piece of it. And I oversee and run the state's rural hospital program and work with 8 small rural hospitals in the state. And I give you some good examples. I live in Worcester. I know what Worcester's doing. It's great, but there's also some good rural examples as well. We work with we're working with a number of rural communities right now on the transformation of healthcare and the engagement of their communities in the process. And we're getting to a certain point. We're still working on it. But like the North Quabbin area is doing great on it. We're working up in North Adams still on what's happening up there. But anyway, but I think you've got this is kind of the stick model, so it's, I keep going with what you're doing. I'm not saying to change this, but there's other leverage points that are more the carrot model that we can talk about in the department where we could all be better aligned in getting the hospitals to the place that I love where you want to get them. That's the same goals that my office is trying to get them to as well. And I see a lot of other leverage points to do that, at least for the small rural hospitals. I think that you know, they really want to do the right thing in most cases, but we need to get there with them in some other ways as well.
So this is just one part of sort of an overall thinking of the role of public health and health planning.
Yes, exactly.
And so it does need to be done in concert with other things that are happening and coordinated within the department. So, you know, we'll definitely note that point. And
I wasn't harping on that point. I'm just saying that I think we've got other leverage points and things that we can do with communities and with the hospitals to get, because I love your vision of you know, that's where we're trying to get these folks too, but we can, there's other leverage points in addition,
All right, so these two last recommendations, I think we'll probably go through a little bit quicker, and then there's one, there's a fifth issue that will represent sort of definitely a newer change. So the next recommendation essentially relates to the SHIP. There's lots of opportunities to align DON CHI-related investments with other sort of statewide initiatives, but a major one is that the state has undergone a process to develop a state health improvement plan, and there is a lot of concerted thought about how it is that we can more intentionally align community investments with the objectives and indicators that are in the SHIP, so that we're sort of maximizing our opportunity to see shared objectives across the state being worked on at multiple levels, and for there to be opportunities for shared measurement as well. So the recommendation simply is that, and we don't know how the mechanics of this might work, and we went back and forth in terms of how prescriptive we should be with this, and landed in a place that I think is probably a really decent place that probably too many people shouldn't have a problem with, which is to say that everyone's going to need to get familiar with the SHIP and understand what it is and the content of it and what it's trying to accomplish. Through the process of developing your local community health assessment and community health improvement plans, or your logical process for developing ways to invest in community health, we want to make sure that if there are alignment opportunities, that we're taking advantage of them. So if you're working in a particular objective area, that we maybe at least consider using the specific objective language that's in the SHIP, so that we're again maximizing this opportunity to do things in consistent ways and to measure them consistently.
I think we still sort of have a identity problem. I still think that most people in the state don't know what a CHNA is, and you know, I've always felt that, at least where I am, it takes a lot. People think it's China without the I. I think we have a long way to go to really. I mean, it's the 20-year anniversary.
Well, the Fed is called
20 years.
CHNA's Community Health Needs Assessment.
Right.
So
But that being said, you know, and the idea that you know, PPH is thinking about pulling away from support in some level, or sharing that support among other entities, is not helping, you know, sort of us trying to, you know, assert our identity or get more people on board with CHNA. I mean, I think that that's something we struggle with all the time. But now, I mean, the hospital CEO might understand, but the finance, you know, officer doesn't. So we haven't really drilled down in agencies and in institutions that we work with all the time what the CHNA is. And so support from the state, I think, would be beneficial. I mean, we certainly don't want to pay for it, right? Nobody wants to pay for it. But thinking about something like the PFAC, which is now mandated, and the PFAC, the patient family advocacy groups, each hospital has a PFAC, and the PFACs are now supported with through Healthcare for All, for example. So they have conferences, they have a website, they have webinars, they have training, they have infrastructure. And, you know, I guess infrastructure costs money, but because those were mandated to have a PFAC, with that came some infrastructure and support. So the PFAC, now everybody, I think more people in our hospital knows what a PFAC is than a CHNA. A PFAC, I don't know how many years it's been around, maybe 10, maybe less?
Yeah.
No, PFAC.
Oh, PFACs.
Yeah.
Oh, yes, I just wrote it.
Yeah, so I think that's, it still is an identity problem. And so
So you're
those of us-
arguing for being more prescriptive in terms
Not
of?
prescriptive, but more infrastructure, more supportive, more.
So one of the
supportive.
things-
I don't want,
yeah.
I think people who are running these know how to run coalitions, but they sort of were hanging out there by ourselves, and maybe, I don't have any resources to have a website per se, or person to do it. But if there was like a statewide, I mean, maybe there is, but, if it was something that everybody knew that they could, link onto their, email address, so people would go there and actually, have it.
So one of the things
I
that
agree
we-
with her, sorry.
Yeah.
Okay, go ahead.
Well, I think we tried to get to that when we have sort of interchanage, we have the Southeast,
Yeah.
which has the six
Right, and I know
chanaz.
it's hard to go to more than one Chinook. It's hard enough to go to one Chinook. So I know that is really important. But we have these save the dates. We have these other kinds of times that David and Dave are organizing, and we get there and it's sort of cathartic almost, like, okay, there's other people out there, we get it, that get it. Because most of us, I think, are probably doing it in isolation, and then there's this, there's people who know what we're doing, but we're most of the time explaining still, after 20 years, what we're doing. So
we talk about that a lot too, and we actually have a couple ideas about how DPH might be able to support various types of processes a little bit better. And the one recommendation that we have at the end might actually create some resources that could be shared in some way to do some sort of system-wide capacity building and support. So that's sort of out there. This recommendation, this is just so high level at this point, we don't really know what it all means essentially, but
Seems like a good idea.
it seems like a fabulous idea. It really it aligns with sort of how it is we're thinking about the ship. It aligns with just general DPH priorities to be much more mindful about measurement. So we want to be able to take a look at a snapshot of the DON-CHI program as a whole. We want to be able to look at all the investments that are made, say, over a period of time, and try to link it up with the types of programs that it's supported, the types of initiatives it's supported, and look at what its overall impact on community health is. So a goal of ours is to really be pursuing the internal processes at DPH to come up with a framework for that. And then at the individual CHI investment level, one of the things that we want maybe to see is that there might be more direction towards more resources towards evaluation and measuring. So that is just something to keep on the radar screen and to think about as an issue that is high up on our agenda and something that we would obviously love to hear more ideas from everybody who are stakeholders in the process. So let me just jump to this, all right, because we're going to run out of time. The issue of geographic disparity in the DOM program is just, I wish we would put one graphic in here to demonstrate it, but it's severe and it's real, and we want to think about a way to alleviate that to a certain extent. So the idea is that we would have a shared pool of funds that would be available to support trying to put some more equity into the system in a variety of different ways. And the way that would be funded is through a percentage of each DON taken off the top to support this new statewide pool of funds. And we've been talking sort of about what that might actually mean in practice. A very small DON might not be asked to have anything taken off the top, potentially. We might sort of think about some sort of a formula so that the larger DONs are putting in a larger share of funds to this overall pot. But the sorts of things that we heard from people that they would like to see actually come somewhat in line with some of the things you're talking about. Actually putting money directly into geographic areas of the state where there is very little or no funds coming from DONs. Thinking about investments that would try to address specific disparity-related issues in specific populations. Thinking about, this is an interesting recommendation, thinking about putting more money into areas that are really demonstrating high levels of success. That's sort of a different way of thinking. DPH often puts money where it's the greatest need, not necessarily thinking about who is actually producing the most impressive outcomes. And then I bolded this last one because I think that in our internal conversations we keep coming back to this more and more and more and more, which is to figure out a way for this shared pool of money to support to be defined statewide activities or investments that are overall supporting the types of things that the DON CHI program is all about. So that could be providing support around advocacy for specific policy levers that would be relevant to communities and other stakeholders. It could be providing capacity building support around, say, evaluation or coalition building or whatever. So that's that's sort of, I would say, that's kind of more where our current thinking is, but it's all for conversation. And I think that one thing that we'd want to do is create some sort of a statewide committee that would be vested with helping make decisions about where these funds are going.
So, and I don't feel like PPH needs to replicate that. I mean, I think that there are a lot of resources out there that if we could say, we'll spend the money, not have to just give it to a pool, but decide, we want X for this contract with X, like HRIA to do X in terms of technical assistance. I mean, I think that's I think that flexibility is important rather than saying it's going to go, unless DPH wants to get to that high level of providing that kind of technical assistance. Because that's really what people need, I think, in these coalitions. But, so I don't know. I mean, I think it's more just communication. I don't know. I don't think it's something that people really are going to say they're going to additional pay funds for from the DON. That's a hard sell, I think. To the hospital, to the community.
I don't know, we did it in the Southeast with our inter-Chana, the 6 Chanas. We each put in, many years ago, $2,500 a piece. We had one Chana, didn't have any money, and we didn't keep them from being included. We said, okay, we'll find another way for you to participate. And for 3 years running, we put on a conference, that we opened up to the whole state, but that looked at, in particular, our first one was around how were the different Chanas distributing the DON funds. What was working for your community that might work for our community? Fall River talked about how they created positions that they funded to do the different initiatives. On the Cape, we decided to do it as a grant. And so we wrote an RFP that we took a lot of time to look at. And so we shared that, and none of us balked at taking that $2,500 and putting it, I think, forward, because we saw that there was a communal, this was a community effort beyond our own little community into the more Southeast community, but that it benefited all of us to hear about what were best practices, what was going on. And we've done it at the statewide level with the statewide Chana, twice now having, and all of us have contributed to that. So I don't think it's such a hard...
That's a different, like $2,500 is different than sort of a percentage of... Yeah. It's different.
Right, it is, but I still think, I don't think they're talking about putting 25% of it. I think they're talking about maybe 1 or 2% would be.
Some pretty close to that.
Really?
I think I've heard a lot of these types of discussions about what are we going to spend the money on and how much are we going to get and how are we going to fight it out. And I think that I think this is a great proposal, and I also think that it will be very important over the first few years of such a statewide pool existing to have very concrete benefits to every Chana and every group across the state. So whether it's the creation of some centralized website that everyone genuinely uses, or whether it's whatever outcome it might fund, it just has to be concrete enough that people see the benefit of having the dollars allocated that way. I don't think it'll feel like a loss. I think it'll feel like a win for everyone, including those who don't have any local DONs.
And I think that's what's important, the ones that don't have the local DONs. How healthy can my community be if the community next to me is not healthy, if they don't have the resources that I have? Because people are transient. They're moving from community to community as their jobs change or whatever, their family structure changes. So, you know, I mean, I would hope that most people would be open to that being distributed in a more equitable way.
I apologize if you covered this before because I came in late, but I have two questions. One is that, do you have any additional support for newly formed coalition, health coalition? And also, do you put in resources for information dissemination, or like, you know, the result of the community assessment, you know? Because oftentimes I find that, you know, because we're so new, we don't even know how to, you know, how to navigate the system to be at the table. And so from the very beginning, you know, we're already missing out. And because you know that if you don't have access to this information, and you know, you will never be part of it. And so, and then the other question I have is that I was wondering, do you provide any additional, again, you know, special support for, because different coalitions have different needs and they're at different level. And so maybe the newer formed coalition might need more technical support on maybe, you know, grant writing or whatever, or to learn how to work together. Yeah,
So I'll try to really briefly answer your question because it's, you know, pretty complicated. So in the beginning, I think maybe part of one of the things you missed is we did talk a little bit about, as part of the vision, that this geographic, it wasn't just geographic lack of distribution, but it also sometimes affected specific populations. So there may be a coalition, a broad coalition that's working, let's say, with, I don't know, Somalis, and so maybe that would, so that's part of this conversation. And so depending on whether the coalition is working statewide, and then another approach, if it's specific to a community, ideally, it should be attached to then something bigger. So, you know, as part of a whole community health improvement plan, there should be a way, and so whoever is kind of the lead on that really should be looking to other coalition, you know, other groups that are more grassroots to assist them with particular populations. So I think there's multiple ways that can be resourced, but I think it's an important thing to bring up to kind of have on the menu of things.
This is probably an obvious answer, everyone has an obvious question, but I just haven't read the regulations probably to the degree in which I should know them, but can DPH or some kind of DPH initiative be funded for DON at all?
Yeah.
DPH would not be one.
Right.
Your initiative.
We're the
would be
facilitators
excluded from any
of this, and we do not hold any of the money at all.
So we can be sort of educating and maybe supporting ideas like trying to align and make investments with things like the SHIP. That's sort of like what DPH's role in terms of what DPH's priorities will be. So I think that is it, Kathy. Yeah. I guess here's another slide.
We're up to 25 slides. Yeah, maybe I should ask again.
We touched on this just really briefly. We touched on it already, though, that we're sort of thinking about just internal process and how we could potentially make an upfront application from the applicant have more information attached to it and figure out a way for there to be multiple stakeholders within DPH to have an opportunity to sort of see what's being circulated at a first level. So we're trying to get more system-wide DPH input on the front end of these applications. So I'll just, that's all I'll say on that right now. So the rest of this was just all about having conversation, which we've basically been doing as we've gone through. We have like 6 minutes left. These were the specific questions. Again, these are all the sorts of things that you guys have already been responding to. What do you think of the proposed plans for the role of community coalitions? Your reaction to the proposed goal of aligning investments with the SHIP? Opportunities for this new statewide pool of shared funding.
We just anticipated your needs.
Yes, exactly. And what are the opportunities, potentially risks you see in more intensely aligning with the community benefit processes? So anything that you haven't already said, please say it.
I may have missed this, I did come in a few minutes later, but I was wondering, as we re-examine the relationships between the different entities, the hospitals, the community-based coalitions, the CHNAs, what role will DPH have in providing oversight? Anytime we're talking about money, there's the potential of competing agendas. And, hospitals, quite frankly, right now are not motivated by prevention. We're trying to get them there, but they're not quite there. They're not putting their dollars so much in prevention as they are in services because they can get money for services. So I guess I'm wondering, what the role is of DPH in providing oversight and requiring the hospitals to do what they agreed to do.
Well, they have, so that is the one thing we can do, and you do, and that's why we have these guidance. So, in the old days, it was very vague guidance, so it was really harder as an oversight to kind of hold either hospitals or communities or whoever to a certain set of agreed to processes. In this case, we're trying to set these up in such a way that it's pretty clear generally what needs to be done, and that is the role of DPH, is to assure that that happens. And in the end, we do make the recommendation to the Public Health Council as to whether a CHI is agreeable. And so that's sort of our one last leverage in that way, to say, if we can't come to agreement, which has never happened so far, I've worked on some pretty hard DONs, and I think in the end we've actually managed to come to pretty fair agreements by trying to live up to the visions that we have for this. And then I think ongoing, it is the role, and many times we're called upon to say, well, I don't think this is exactly happening, or can you help with this, or we want to change this, and that's our role to facilitate that conversation.
David.
Yeah, you referenced a couple of times about alignment with the state health improvement plan, and I think that since it's not DPH's plan for DPH, but it's DPH's plan for the state, which means all of us,
Yeah.
then there needs to be some kind of community education process
Yeah.
around what the SHIP is and
Yeah.
what it means and what's in it.
That's Michael's job. But no, that's a very
We'll get
good
to
point, David. Yeah, no, I think that's a
Good thought,
great,
David.
yeah.
We really didn't roll it out publicly, except for the fairly broad-based group that contributed to it, and we probably should.
If you're asking people to align with it, they have to know what it is.
Yeah.
I think especially in the western part of the state.
Right. I mean, there were a lot of people involved in the construction of
Right,
it, but
right.
of course, just like we said with any
Everybody.
improvement plan, right?
We didn't
Right.
have a public
Right.
event
Yeah.
to introduce it, and it wasn't
Yeah.
mailed out. It is available on the website.
Right, but there might be a little
No, I-
campaign to
Yeah.
get it out.
Yeah.
And we could do that. We still can. It's on the
Yeah,
site.
Part's not out of the barn on that yet. Or the cow's
Yeah, just read a paper called The Community Health Strategist, and trying to think about how to align an image of alignment, I guess, when you're talking about a statewide plan to, we don't have county government, but local government, but all the community health planning and assessments are going. So that idea of a centralized person or committee or body to help with that alignment, and alignment of resources as well as priorities and measurements. So I don't know if you can build that into the...
Yeah, I mean, that could work, it could expand the role of that, possibly of that committee, that's an
Yeah.
idea.
What's the committee?
Well, a proposed committee, there is no committee. A proposed committee, because if we were to have this this pool of money, we can't, DPH can't just say where it's going to go. It needs to be a broad-based, neutral group of people interested in, things in community health that is helping to put that out there.
But so Judy, are you suggesting that the role of a group like that could be broadened to be kind of a advisory group to DPH around all of the DON process ongoing?
So I was
how it's
thinking of-
working?
Yeah, I was thinking of the role not just be around DON,
Oh.
but assessments in
Yeah,
general, and
Yeah.
alignment
Yeah.
of priorities from the
Yeah.
state to the local community, and maybe a two-way communication.
Yeah.
That's not exactly what you said, but I kind of heard David say that, so I put it up on the screen. Because I already got it. Anything else? Oh, Donna's telling me that we need to do evaluations. Please do your evaluations.
One thing I guess that I'd like to say is that we maybe, I don't know, Ben, we could figure out how to do this, but to make sure that you have access to the questions again, so that if there's something either you didn't get to say today or you have some more ideas, you could write to us in response to those questions, because we didn't exactly formally present them. So I want to make sure everybody had a chance to give their input into it. So
And this is my email address, for
send it
those
to
of you
Ben.
who don't have it, and this is my phone number. I am based in Northampton, where I live.
Well, thanks for sticking to the end.
Okay.
Appreciate it.
Yeah, thank you, everybody.
I'll take your evaluations unless you need CEUs, and then they go into critical.